Hi guys, in this video we're going to talk about the anatomy of the large intestine. So where does the large intestine lie? It lies almost in all of the regions, all right? So you get to see it in the right iliac, the right lumbar, piece of it would be in the right hypochondriac region, in the umbilical. You get to see it everywhere on the left. But the most important thing you guys need to know is that the vermiform appendix lies in the right iliac fossa, and this is very important. This is the vermiform appendix here, all right, hanging out from the cecum, all right, and this is in the right iliac fossa because this is important in case of appendicitis, all right. Now, moving on, the external features. So basically, the large intestine starts from the cecum, and then it continues as the ascending colon, and then the transverse colon, and then the descending colon, and then we have the sigmoid, and then we have the rectum. And why do we call it a cecum? Because it's a blind-ended pouch. Cecum in Latin means blind-ended pouch. How can I know it in the lab? Is that it receives the ileum from the side wall. This all parts of the intestine they are basically a tube that has opening from here and there, except the cecum. It's basically closed from one side, and it receives everything from the ileum from its side wall. So that's why we call it cecum, and it lies in the right iliac fossa, and the appendix can be hanging off from there. All right, and we're going to talk about that in a while. Now, the important external features of the large intestine or the colon is basically we have something called the Taenia coli. What is Taenia coli? The Taenia coli is it's like ribbon-like. It's kind of modifications from the external longitudinal muscle layers of the colon, and it condenses and it comes all the way. We have bands of muscle fibers anteriorly and posteriorly in the colon. They are important because they are trying to shorten the wall of the large intestine. I need to get a lot of spaces to get enough space to absorb as much water as I can and produce the feces. But at the same time, I want to squeeze them into the abdomen. So thanks for these Taenia coli that are going to contract and cause these saculations or hostrations in the colon. And they are formed because the Taenia coli, these tendinous structures, they are shorter than the walls of the large intestine. All right, so that this is the Taenia coli. This is what we mean by the hostrations or saculations in the colon. And then the last important external feature is basically what we call the epiploic appendages. What is the appendages? Appendages means extra pieces. Epiploic because they are basically coming from the peritoneum. Epiploic name means peritoneum. It's basically peritoneal sacs. They are filled with fat, and we get to see them hanging from the large intestine. So these are the important external features of the large intestine. So moving on, we've talked about the parts of the large intestine. All right, so we have the cecum, we have the ascending colon, we have the transverse, and then we have the descending, then we have the sigmoid, all right, and then down here we have the rectum, and then the anus as the last part of the large intestine. Now, moving on, we need to know what are the pieces of the large intestine considered to be intraperitoneal and what are the retroperitoneal structures. Now, the only intraperitoneal structures are the structures that have mesentery or peritoneal ligaments. It means these parts got successfully into the visceral layers of the peritoneum. If you guys need to get more information, you can watch the peritoneum video. All right, so what are the intraperitoneal pieces or parts of the large intestine? They are the vermiform appendix because this is the appendix, all right? This is the cecum as it receives the ileum, all right? So the appendix, it has a peritoneal visceral layer. So that is the mesoappendix. The transverse colon, if you guys look at this picture, this is the transverse colon. It has a peritoneal ligament posteriorly, which is the transverse mesocolon that attaches the posterior parts or border of the transverse colon to the posterior abdominal wall and pancreas. However, anteriorly, it's attached to the greater omentum, and we've talked about that in the peritoneum video and in the stomach. All right. because it attaches the transverse colon to the greater curvature. So if I try to reflect the greater omentum back, so I can see what's happening in the abdomen, I can see the transverse mesocolon attached to the transverse colon posteriorly. So this is intraperitoneal. And the sigmoid, if you guys look at the sigmoid colon, you can see this peritoneal ligament, which is attaching the sigmoid colon to the posterior abdominal wall. This is the sigmoid mesocolon, all right? The other parts, which is the ascending and descending colon, they are basically retroperitoneal. They are not suspended by peritoneal ligaments, all right? Now moving on, let's start with what happens to the chyme as it reaches the cecum. It comes in from the ileum and it's safeguarded by the valve, and this is what we call the ileocecal valve, because we would like to have to make sure that the chyme doesn't go back to the ileum after reaching the cecum. So it comes in here, and this is the cecum, and then we have the appendix, all right? So this is the vermiform appendix. All right, so what would be the position? It would be retrocecal. It's in most of the cases, it's behind the cecum. Sometimes it hangs in the pelvis, and that would be 20%. It could be subcecal, all right, but this is very few population or percentage, all right, and it could be post or pre-ileal, all right, and this is very rare, okay? So most important thing is you guys need to know that in most of the cases, the appendix is expected to be seen behind the cecum, retrocecal, and this is important during surgeries, and that helps in finding it if you would like to do appendectomy. Okay, so what is the clinical significance of the appendix? It's important to know that if we have a pain because of the appendicitis, sorry, that pain would be in the umbilical region. Why? You guys can watch the innervation of abdominal viscera to understand why would an initial pain due to appendicitis would cause dull pain around the umbilical region, and then if the inflammation reaches and touches the parietal peritoneum, it becomes somatic pain, and it becomes very sharp and localized to the McBurney's point, which is basically a point of intersection between, not intersection, it's a point it's a point between the 2/3 line from the umbilical region here and 1/3 from the anterior superior iliac spine, because that shows you where is the base of the appendix. So if the patient shows you a severe pain in the right iliac region at the McBurney's point, you would expect that this patient is having appendicitis. And because the pain is coming very high, and the inflammation is very high, and that causes the appendix to reach the parietal peritoneum, and the parietal peritoneum is supplied by somatic nerves. Somatic nerves are localized sharp pain, so that gives me a sign, and that happens after some time. It doesn't have initially. All right, so this is the clinical importance of knowing the location of the appendix and the type of innervation. And during surgeries, the idea that the tinea coli, we have one anterior and two posterior in the ascending colon, they all come together and unite at the base of the appendix. It helps the surgeons to find the appendix during surgeries and appendectomy. All right. Now moving on, we have the ascending and descending colon. So in that picture, we've removed the ascending and descending colon. You guys can only see that on either sides of the ascending and descending, we have what we call the paracolic gutters or recesses. And this is important because if you think about the peritoneum as it comes and gets reflected back, it means if I have my colon here, and I have a peritoneal reflection, it comes and goes up, all right? So think about that as a piece of silk or something. It comes here and it reflects up, and I have an elevated part of the colon. I would expect to see on either sides, I would expect to see a recess or gutter where I can see accumulation of fluid in supine position if the patient is lying supine and that patient is having any inflammation, peritonitis, any problem in the abdomen. I would expect to see the accumulation of fluid in the paracolic gutters, and that's because I have a peritoneal reflection here as it comes over the ascending and descending colons. So that would be accumulated here. Okay, now moving on to the sigmoid colon. All right, so in the sigmoid colon, why do they call it sigmoid? Because it looks like a sigma, which is a letter in Greek, and the sigmoid colon starts from the level of the sacroiliac joint, and that is S, all the way to the level of the third sacral vertebra. So S3 is the end of the rectum and the start of the anal canal. All right. And then we have the rectum. The rectum starts at the level of S3. So if that is my S3, it means here my rectum is going to start roughly in that diagram. So the sigmoid colon was above that, and the rectum is starting here, and it goes all the way, and it ends at 1 inch below the coccyx. So if that is my coccyx, then 1 inch below would be the end of the rectum. Why the rectum is important? Because it has important relations. The important relations would be that anteriorly there is a prostate anterior to the rectum, and superiorly we have the rectovesical pouch, and because the rectum is here and the urinary bladder is here and the prostate is here. So anteriorly, superiorly, I have, as the peritoneal comes in and deflects up, I will get the rectovesical pouch in male and rectouterine pouch in female, superiorly, anteriorly, superiorly. And that is a place where I can also find accumulation of fluid in standing position. So it's important to know that. And down we have the prostate in male and the vagina in female. So that helps us if we were to do the PR exam. If the doctor would put his finger in the rectum, he can palpate the vagina and look for any problem. And the same thing happens in male, as we can palpate anteriorly, we can palpate the prostate and find out if there is a tumor or something. Okay, so this is important anterior relations to the rectum. Posteriorly, of course, you have your bones, the sacrum and coccyx. Now the peritoneal reflections, they are different in the rectum. So as the rectum comes here, okay, if you guys look at this picture, we have the peritoneum is basically coming anteriorly and laterally in the upper third here, okay, and in the middle third it comes only anteriorly, and in the lower third it's not related to the peritoneum. Okay, so here it's anteriorly and laterally related to peritoneum reflection. Here it's only anteriorly, and here it's not covered, or it's not related to the peritoneum. Okay, moving on to the anal canal. If we look at the anal canal consists of 3 parts. It's basically half and half. One half is coming from the during development, it's coming from the hindgut, and the lower half is coming from the proctodium. This is ectodermal in origin, and this is endodermal in origin. So after development, there will be a rupture in the cloacal membrane, and then they will come in a continuous relation together. That was closed and that was closed, and then it will rupture and they will become continuous together. Why is that important? It's important because the innervation here is different. This is autonomic, it's insensitive to pain. This is somatic innervation. This is following the histology of the gut tube, which is simple columnar epithelium. This is following the histology of the skin, which is stratified squamous. And of course, above the white line of Hilton, we have a transitional zone, and we have the true skin. Okay, and then another thing is because the blood supply also of the upper half is basically following the hindgut, which is coming from the inferior mesenteric, and the below part is systemic, and that is coming from the internal iliac and internal pudendal. So everything here is following the gut, and everything here is following the skin, and yeah. All right, so here we have the pectinate line, and why do we call it pectinate line, which is the line between the hindgut and the proctodeum or origin, because it looks like a comb. Pectin in Latin means comb. Okay, so this is the pectinate line, and that is what separates this zone from that zone. And then we have an elevation. These elevations are actually what we call the anal columns or columns of Morgagni. Why do we have these columns? And between and in between the columns, we have sinuses. So we have a column, sinus. Why do we have that? Because we have a huge amount of venous plexus in the submucosa, and because I have a lot of venous plexus in the submucosa, that causes the mucosal folds to form columns. So these are all columns formed by rectal venous plexus. Okay, we're going to talk about that into more details. I think so. Okay. So now moving on to the arterial supply of the large intestine. Now, guys, remember that we talked about the arterial supply, and we said that the celiac trunk is the artery of the foregut, and here the superior mesenteric is the artery of midgut, and the inferior mesentery is the artery of hindgut. Now, in the large intestine, we have this all the way up until the junction between the right 2/3 of the transverse colon and the left 1/3. This is considered to be midgut. Okay, so this midgut is coming from arterial supply from SMA, the superior mesenteric, and the 1/3 and the descending sigmoid, rectum, and anal canal are considered hindgut, and they are supplied by IMA, the inferior mesenteric. So what are the arterial supply that are coming from SMA? It's very simple and easy. This is my right side, and this is my left side, and this is my middle side. So the first artery that goes all the way to supply them, it would be the ileocolic. So this is your ileocolic. So your ileocolic comes all the way. It gives ileal branch, it gives anterior and posterior cecal, and the appendicular branch to the appendix. So the important thing to me now is that the cecal branches, all right? So from the ileocolic, I have the cecal branches because cecum is part of my large intestine. Moving on from the SMA, I have right colic because this is for the right side. And also I have the middle colic. They are all coming from the superior mesenteric. However, from the inferior, I have the left colic and I have the sigmoidal branches. Now, all these branches together, they will form an important artery called the marginal artery. Why the marginal artery is important and why is it formed of? How will you guys remember that? Remember that on the right side, you have two branches coming from the SMA. In the left side, you have two branches coming from the IMA, two from the superior mesenteric artery and two from the inferior mesenteric artery. These ones will give ascending and descending branches, ascending and descending branches. And these will do the same, ascending and descending, ascending and descending. However, the middle colic, which is coming from the superior mesenteric, because it's the only one that's in the middle, it will give right and left branches. What will happen is the ileocolic ascending branch will anastomose with the descending branch of right colic. The ascending branch of right colic will anastomose with the right branch of middle colic. Now the same story happens on the left side. Sigmoidal branches will give ascending branches to anastomose with the descending of left colic. And the ascending of left colic will anastomose with the left branch of middle colic. So again, here I have ascending and descending, and in the middle I have right and left. When they all anastomose together, they will form a marginal artery. All right, and that marginal artery is important because after forming this marginal, they will send straight arteries, the vasa recta, to supply the colon itself. Why is it important? If I have a blockage in the superior mesenteric artery, the inferior mesenteric artery will be able to fill the marginal with blood and take over the blockage. And the same story happens if I have a blockage in the inferior mesentery. So it's very important collateral circulation to save the colon if there is blockage in any one of the two major arterial supply of the large intestine. Another important information is basically what we call the arch of Raylan. The arch of Raylan is part of this story. It's basically a communication between the ascending branch of left colic and the left branch of middle colic. So this is basically an arc that causes connection between the inferior mesenteric and superior mesenteric. They are all important as collaterals because they want to take over any blockage in the arterial supply of the large intestine. All right. So moving on, talking about the anal canal again back. Of course, the arterial supply would be the same as veins, but I have here picture of veins because I want to talk about the portocaval anastomosis. So you guys remember that we said that again from the aorta, we have the celiac, we have the superior mesenteric, and we have the inferior mesenteric. Now, the inferior mesenteric gives you the superior rectal, all right, because we said that above the pectinate line here, above the pectinate line, this is part of the hindgut. So from the inferior mesenteric, all right, it goes all the way and it supplies the superior part of the anal canal and rectum. Now, because the lower part is actually related to the pelvis and perineum, it's coming from systemic circulation. So what happens to the aorta, you guys know that it bifurcates as two common iliacs. The common iliac gives internal iliac and external. And because the internal iliac artery is the artery of the pelvis, so that will give me the middle rectal. Okay, now very important branch of the internal iliac is the internal pudendal. Internal pudendal, the name pudendal means shame area because that supplies the pudendal region, okay, the genitalia. Okay, so the internal pudendal takes care of the blood supply of perineum, and because the anus is part of that, so the internal pudendal is what will give me the inferior rectal. So again, from the inferior mesenteric artery, I have the superior rectal, which is part above the pectinate line because this is part of the hindgut. And then I have from the internal iliac, I have the middle rectal, which gives the part that's above the white line of Hilton. And then from the pudendal, I have the inferior rectal. But the inferior rectal is a misnomer. It does not supply the rectum because I don't have rectum in perineum. I only have the anus. So it supplies the lower part of the anal canal. Now, why is that important? Because you guys know that the superior mesentery, the celiac, and inferior mesenteric, now we're going to talk about the veins, they all drain into the portal vein, right? Now, this is a portal circulation. So everything up until the inferior mesenteric, they drain into the portal and into the liver. However, the systemic, which is basically draining into the common and internal iliacs, it goes to the inferior vena cava. This is a systemic circulation. So if I have a portal hypertension, and if you guys don't know what's portal hypertension, you can go all the way and watch the liver video. Okay, so if I have liver cirrhosis or any liver disease and the portal vein is blocked, so the blood cannot go into the liver. It comes back all the way here. And because I have an anastomotic network between the portal, the veins that goes to the portal circulation and the veins that goes to the systemic circulation, these anastomotic networks are going to be opened because the blood wants to escape and it cannot find its way back to the liver. So it will come back and that will form the hemorrhoids. Okay, and those hemorrhoids, the anastomotic networks are going to open and that can cause biles. Okay, so this is a site of portocaval anastomosis, and that can end up having hemorrhoids, pathological hemorrhoids, if there is liver disease or any other problem. So here again, we already talked about how the anal canal is formed by the rupture of the cloacal membrane between what's coming from the hindgut and what's coming from the proctodium. And I already told you guys that above the pectinate line, because that's coming from the gut, this is an insensitive area, and this is because it's supplied autonomically. However, down, because that follows the skin, it is considered to be pain sensitive because it is supplied by somatic nerves, right? Thank you guys for watching. I hope you grasp the whole concept. Don't forget to like and subscribe, and see you in the next video.